I'm going to speak about these human type 1 interferonopathies, and I'm going to start off with a French restaurant. And the reason why I started with this is because this man is the son of this man. And this man is Pierre Lebon, who used to run the virology department. He moved from a hospital, I can't remember, to Cochin, and now that department, Saint-Vincent-de-Paul, and now that department is run by Flore Rosenberg. And also we have here a man called Ian Gresser, who used to work in Paris too, and I'll speak about each of these people. And then finally Jean-Laurent Casanova, who's been very influential in persuading me that this idea is an interesting one and worth pursuing. So what I'm going to talk today about then is these human type 1 interferonopathies, and I'm going to give you a definition here. These are, well, effectively what we're talking about are inborn errors of enhanced type 1 interferon and signaling. And you've heard already from Alain about various monogenic disorders involved in immunity or leading to a dysfunction of the immune system. And I'm going to talk to you about these inborn errors of too much interferon, effectively. So that begs the question then of what are type 1 interferons, and these are the primary antiviral cytokines that we produce. I think I'll say it here: we are effectively, as humans, we are at war. We are at war with viruses, with bacteria, with other organisms, and these are central or a very important part of our armory that allows us to fight that war successfully. And interferons were first described by Alec Isaacs, a Scotsman, effectively, and Jan Lindemann, a Swiss man. And they are both now dead. But in the early 50s or late 50s, they described a factor that was released by cells in response to a virus, but then could protect other cells when they were infected by a virus. Effectively, this substance could interfere with the killing effect of viruses, and they termed this substance interferon. Now, as Alain has indicated in his tremendous lecture that he's just given, just one part of it he's been talking about this issue, and so I'm going to pose a question here, which is: if we are at war with viruses, if we're at war with these external creatures, how do we recognize them? How do our cells realize the fact that we are being invaded, that there is a pathogen at large? And essentially speaking, we use viral nucleic acid to recognize those enemies, if you will. Viruses actually aren't composed of so much. The major component, if you will, of a virus is its nucleic acid. And evolutionary speaking, since a virus needs its nucleic acid to be a virus, it seems to be a very good way of, if you're going to think about a signal which tells you that there's a virus there, it seems a very reasonable thing to choose that part of a virus which is essentially invariant, i.e. the nucleic acid. But that poses a biological conundrum that Alain has already touched on, which is that if you use viral nucleic acids as your trigger to recognize non-self, you have a risk of confusing non-self with self, or self with non-self. But I'll come to that again. But here we have these various alarm systems. So there are various different ways that we recognize that we're being invaded by a virus. And in a sense, it doesn't really matter which of these antiviral systems are triggered. They all effectively induce what can be termed a type 1 interferon antiviral state. So my point here is that irrespective, if you will, of which of these systems recognizes the virus, they all go through this interferon stage, and that interferon stage then induces a tremendous amount of biological change, and that biological change is mediated both by other innate immune molecules, but also by the innate immune system talking to the adaptive immune system. So you have this conversation going on between the innate immune system and the adaptive immune system. Okay, so I showed you a picture earlier on of Ian Gressa. I mentioned that he's an American actually who worked in Paris for a long time, and he published with his group in 1975 this paper in Nature, and it was a description of what happens when you give mice interferon after birth. Okay, and this paper effectively was about the consequences of giving mice interferon after birth every day for continually, and if you gave that up to 8 days, effectively, all the mice would die. And what they would die of, well, I'll come to that in a moment. He then, what he also said in this paper, what they also said in this paper, is if you gave the mice every day interferon every day for 6 or 7 days and stopped, the mice were, those mice lived. But then he published the next paper the next year saying that they lived, but then several months thereafter, they also developed a problem. And so summarizing those two sets of data, what he says is that while investigating the effect of interferon on the growth and development of newborn mice, we found that daily injection of mouse interferon resulted in extensive liver degeneration and death between 8 and 14 days. So if you treated these mice and didn't stop the treatment, by 14 days at maximum, they would all be dead. And they died of a liver disease. However, if you stop the interferon at around day 6 or day 7, these mice survived initially, but then they died thereafter, several months later, but not of a liver disease, but of a renal disease, a kidney. They had a glomerulonephritis. Now, I'm not a mouse doctor, I'm not a vet, mice don't really interest me. However, there are various things we can learn from this. The first is that interferon is a poison, potentially. And I think they wrote this paper at the time, partly, you know, if you think about it, the idea of being able to purify and use medicinally a substance which has a high antiviral capacity is very compelling. And this was a warning, if you will, to say that although interferon could be great in a therapeutic context, it also is a dangerous molecule. It's extremely powerful. The second thing it says is that actually, the second thing it says is that you can get at least 2 different types of pathology consequent upon interferon exposure. In one set of mice, they got a liver disease. In another set of mice, they got a kidney disease. So it's causing multifactorial disease, if I can use that term. And then the final thing I think is very interesting is the idea that you can give interferon between day 0 and day 8 of life in a mouse and stop the interferon, and they develop a pathology which is separated in time by several months. So you have a trigger, you have an insult, you have an exposure to interferon that is then separated from its consequence by a considerable period of time in the context of a mouse life. So, you know, summarizing, interferon is potentially a dangerous material. And it can cause different types of pathologies, and sometimes those pathologies can be separated from the insult by a considerable period of time. And no one had said that before. So, you know, this is important. And what he then did was they wrote a summary paper going over these data in 1980. And this is the bottom line. If this is based on the data that they presented, one might expect to find examples where too much interferon, instead of being beneficial in the context of fighting infection, may actually prove dangerous to the host. And this was the subject of their presentation. And whenever I give this kind of talk, I essentially say, this is the subject of my presentation today. These people effectively predicted, if you will, what I'm going to talk about here. Now, that paper was published in 1980. And in 1984, so, and they also made in that paper they made a prediction. They made they suggested something else, which was that interferon doesn't normally cross the placenta, and they made the suggestion that the consequences of in utero viral infection. So, as we know, some women are exposed to very to viruses during pregnancy, which, you know, in many women actually they don't even realise they've been infected or exposed, but that can have grave consequences for the baby if the virus is transmitted transplacentally. And they made the point that perhaps the damage that those children suffer in the womb when you have in utero viral infection may be as much a consequence of the virus itself and its specific properties as the very fact that there is an immune response mounted against the virus, i.e. an interferon response. And that's still a relevant issue today when we think about what's happening in Brazil and South America with Zika virus, for example. Now, I put that up there because that was 1980, as I said, and in 1984, in the very same city that we are today and in the very same city that Ion Gresser was working in, these two preeminent pediatric neurologists working at the hospital that Alain and I work in described a monogenic disorder. So Jean Ichardi, François Goutier, they described a monogenic disorder where they recognized a group of children who had a genetic disease, but to them, as extremely fine clinicians, looked like the consequences of in utero viral infection. Okay, so this looked like congenital infection, but they couldn't find a bug. They were seeing that there was consanguinity in some of the families, and they were seeing recurrences in siblings. And for those reasons, they suggested that this disorder was familial, with a 1 in 4 risk of recurrence. And they said it was probably genetic in origin, and they were right. And they said, although some features, especially the pleocytosis, so these children have raised levels of increased numbers of white cells in the cerebrospinal fluid, for example. They said that especially this pleocytosis may erroneously suggest an inflammatory condition. And in fact, I think that wasn't quite correct. This is an inflammatory disorder, but I'm not quite sure what they were trying to say, but definitely what we can say, it wasn't a consequence of viral infection. It was a genetic disease, but it looked like viral infection. Now, based on that work, based on those observations, they then went a step further. And with Pierre Lebon and his colleagues, they went on to measure interferon alpha activity in the cerebrospinal fluid of these children. So if you have a disease that looks like infection, and we know that the response to infection is primarily, or at least initially, determined in this context by the production of interferon, well, let's go and measure the amount of interferon in these children. And for me, still, this represents a fantastic piece of clinical imagination. And they were absolutely correct. These children have too much interferon. So we have a disease then that's both a clinical mimic of congenital infection, clinically, radiologically, but also a biochemical mimic of congenital infection. But yet, it's not infection, it's a genetic disorder. Okay, so I started working on this disease in about 1998, and it took a long time to find any genes for this disease, and there are various reasons for that, but one is that this is a genetically heterogeneous disorder. So if you take a group of patients with Aicardi-Goutier syndrome, only a proportion of them will have mutations in any one gene. There are actually now, we know of at least 7 genes which are mutated. If you take a population of patients with AGS, in any one patient, in any one family, it's 1 gene, but there are 7 genes that can be mutated to give essentially the same clinical phenotype. Now, the first gene, which Alain has mentioned already, is TREX1. And I'm not interested particularly in the detail today, but what I want to tell you then is that TREX1 is a nuclease and it eats up bits of DNA. Okay, so it's involved in degrading DNA. We also described at the same time mutations in 3 genes which make up a single complex called the ribonuclease H2 complex. So we can think of these 3 genes or these 3 proteins as essentially one, and what they do is another nuclease. Again, it works on nucleic acids, but in this case it works on a hybrid of DNA and RNA. So this is a piece of RNA stuck on a piece of DNA, or however you want to describe that, or indeed a DNA-DNA sandwich, a double dose of DNA with ribonucleotides, RNA, embedded in the DNA. So it's a completely different substrate in one context, in one sense. It's a DNA-RNA hybrid versus a piece of DNA, but on the other hand, I think we can both say both of these are nucleases. They both work on nucleic acids. Subsequently, we describe mutations in SAMHD1, and SAMHD1 is not a nuclease, or probably not it doesn't probably have a nuclease function, but what it is involved in is regulating the pool of dNTPs in the cytosol, and dNTPs are used to make DNA. Okay, so it's got a different function, but again it's involved in nucleic acid metabolism. And then Alain mentioned in his talk this fascinating molecule called ADA1. This is an enzyme which alters the code, is so-called editing of double-stranded RNA to alter the code of RNA. And the reason why it does that, evolutionarily, is not particularly well understood, or not well understood, but I think is fascinating. But mutations in ADA1 can also cause Aicardi-Goutieres syndrome. So again, it's a different function, but again, it's involved in nucleic acid metabolism. So here's the strap line. Here's the motif. AGS is a Mendelian, a monogenic mimic of congenital infection at the clinical, radiological, biochemical level. And once we'd found some of these genes, it was easy to postulate an hypothesis, which is that a loss of AGS-related protein activity leads to an accumulation of nucleic acid. But that nucleic acid is not viral, it's self. That self-nucleic acid is sensed by those mechanisms, those alarm systems which recognize virus. And effectively, self is misrepresented as non-self. That induces an immune response which gives you a phenotype which 2 of the finest pediatric neurologists ever to live described as a mimic of congenital infection, but was not infection, it is actually a monogenic disorder. And I'm not going to go too much into further detail about this, but what I would say to you is that since that hypothesis was put forward in 2006 or whatever, I think the data that has been accumulated since that time only adds to that theory, that hypothesis. I think we can still be comfortable with that postulate. Okay, so AGS is something to do with too much interferon. And I'm not, the title of this talk is not Aicardi-Goutieres syndrome, so it's about this more general concept of the human type 1 interferonopathies. And one has to question the fact of whether or not this is a useful, or indeed is an appropriate nomenclature. Are these diseases truly to do with too much interferon? I'm going to describe a set of pathologies where there is too much interferon. The question is that actually relevant to the pathology? Because if it is, then treating the interferon might be useful in a clinical context. If it's just an epiphenomena, if it's just a biomarker of no pathological consequence, then treatments won't, directed at type 1 interferon will not be of much utility. So expanding the definition, these are monogenic disorders, and I'll talk about monogenic disorders for the meantime. I will touch, as Alain did, on the way in which I think this kind of work can inform our understanding of more complex, in inverted commas, disease. But these are monogenic disorders in which an upregulation of a type 1 interferon response is directly relevant to disease pathogenesis. And I emphasize this again because if it is directly relevant to the pathogenesis, then the diseases I will touch on, I will describe briefly here, one might suggest that treating them effectively in the same way to either reduce the amount of interferon or block interferon signaling would be useful in any of these clinical contexts. That's the big question. That's the million-dollar question. Okay, so let's break that down a little bit more. If it's not virus and it's not about virus, how might you induce an inappropriate stimulation of the type 1 interferonopathy, of the type 1 interferon machinery? How might that happen biologically? Okay, so I've already suggested that you may simply have an abnormal accumulation of endogenous nucleic acid. If, and it's true, cells are dying all the time, there's a lot of DNA in a cell, there's a lot of RNA in a cell, you must be able to dispose of that self-nucleic acid in an orderly fashion. You must be able to put it in a discrete compartment and chop it up and get rid of it exactly in the same way as at home when you cook a meal. After you've made your meal, you put the tins in the bin, and then you take the bins outside, and then the dustman comes and takes them away and takes them to the tip. And we need to have machinery, cellular machinery, for doing exactly the same thing, for getting rid of waste. And I would say to you that if you have a mutation in a gene that's involved in coding for a protein that does that kind of waste disposal function, then you might be at risk of developing an inappropriate stimulation or engendering an inappropriate stimulation of the type 1 interferon machinery. Now, Alain touched on this, which is that, in fact, although viruses, we use viral nucleic acid as the trigger for recognizing viruses, and we have our own nucleic acids, obviously. There are differences between self and non-self nucleic acids. And it may be not just that viruses, viral RNA has a triple phosphate on the end. It may be that actually we, in some way, mark our own nucleic acid as self. We put a stamp on it, we frank it, and say, this is self, do not respond. Do not react to this piece of DNA or RNA because it belongs to you. Okay, you mark it. And it could be that if you have a mutation in a gene that's involved in marking nucleic acid as self, that could, if you have mutations, then you might misrepresent self as non-self. And I would suggest that this one might be due to mutations in TREX1, for example. This one might be due to mutations perhaps in ADAR1, where you're changing the code of the double-stranded RNA. Now, it may be that actually it's not about the DNA, but it's about, or the RNA, it's about the way in which you sense nucleic acid. So it might be the sensors, the alarm systems. So forgive my slightly embarrassing ways of sort of talking about this, but let's imagine that you at home, when you leave your house to go to work, you have a guard dog, okay? And your guard dog, if you haven't fed your guard dog, it will bark all the time because and when the postman comes and puts the post in the door, it starts barking at the postman. Although the postman is completely benign and you want your post to be delivered. And your guard dog is confusing the postman with a robber because the guard dog is irritated and it wants some food and it starts barking. And in a sense what we have here is the possibility of a receptor that is effectively turned on all the time. It's constitutively active. It's hungry all the time. It's been turned on. And that I'll show you an example of that later on. You could have the same kind of constitutive activation of the system downstream of the receptor, but in the receptor pathway. And then I think it's worth recognizing the fact that, of course, when you respond to a virus, that's very good news. You want to respond to a virus, but you also want to turn off that response to that virus. You want to have a feedback mechanism which allows you to say, right, I've responded to the virus, I've killed the virus, and now you can relax again. Let's go back into the basal state. So there are molecules that are induced by interferon that are actually part of a negative feedback mechanism. And again, if you have mutations in a gene that might have that kind of function, then you could have an interferonopathy. And I won't talk about it further, but I would suggest that perhaps mutations in ISG15 are one such example. And then there's a group of mechanisms which I'm not really going to go into further today. So I first talked about this in 2011 and then published something in February 2015. And then this paper was published last year in the summer. And I only put it up, if this is at all interesting to you, if you're going to read one thing, that would be the paper I would suggest to read, because that's sort of, you know, where our thinking is, I think, in regards of these diseases, this kind of potential pathology, form of human pathology. Now, I make the point that in a sense, these diseases I'm talking about, in one sense, it's simply the flip side of the immunodeficiencies. And indeed, if we look at ISG15 mutations, which I said I wouldn't talk about again, but mutations in ISG15 can give you both an immunodeficiency, where you are susceptible to certain forms of tuberculosis, and an interferonopathy, where you develop features of too much interferon. But my point is, we're talking about the same kind of molecules that you will hear about, you have heard about already, and you will hear about throughout this course. But we're talking about different ways in which they, instead of being immunodeficient, effectively you are revved up, your immune system is hyper-functioning. Okay, so AGS, we might say, is the paradigm, or at least the first type 1 monogenic interferonopathy to be described. And my question now is, do other type 1 interferonopathies exist? Is this simply an isolated example of a very, very rare disease that was described in Paris and that's it? Or are there other diseases where there is too much interferon and where that is interesting to study further? And then I ask you the question, and it's an important question, how do we identify other type 1 interferonopathies? Now, I've touched on the fact that type 1 interferons are extremely powerful molecules, and it turns out that you can't reliably measure the amount of interferon in the blood. You cannot do it. You can measure, you can try with an ELISA, but I would tell you that it really is ineffectual, and I would say to you it's not worth trying to do that. And so what people have done, I'm not the first person to say that, what these people have done, what other people have done before these two papers, but I use these papers as summary papers, is not measure interferon itself, but measure the consequences of interferon. And the consequences of interferon is a very powerful molecule, as I've said, and it drives, it induces, it pushes the production of a very large number of genes, the so-called interferon-stimulated genes, or ISGs. And these ISGs are, it depends how you count them, but there are at least 300, and you can measure any one of those as you wish. And people have measured them in the past in the context of lupus, or first started doing this in the context of systemic lupus erythematosus. And these two important papers were published in the same year, in 2003. Now, we've effectively decided to use this system too to try and identify other type 1 interferonopathies. But rather than do genome-wide gene expression or 300 genes, we've just chosen 6 genes. So we've chosen these 6 ISGs: IFI27, IFI44L, IFIT1, ISG15, RSAD2 and SIGLEC1. We could have chosen other genes. This is somewhat arbitrary. There's a reason for doing this, but it's somewhat arbitrary. And we're simply measuring the RNA, the production of these, the expression of these genes. Here we have controls. So what we do is take a blood sample from a person, and then we measure these 6 genes at one time point, and then you can measure the gene, you can do multiple time points as you wish. These are the expression levels, so red are controls. These are the expression levels of controls. And what I can tell you is that in almost all controls, you almost never produce enough interferon to measure it by ELISA. And essentially speaking, you produce very little of these interferon-stimulated genes. You only produce them when you're infected by a virus. So, of course, there is a risk of false positives with this test, but I will show you that you can use this test usefully to identify genes, in fact. These, in green, are patients mutated in any one of the 7 Aicardi-Gouttier syndrome associated genes. And I point out to you that these, so what we start to see is the vast majority of patients with AGS have very high levels of expression of these genes compared to controls, tremendously high levels. And what we do is very simply, in any one patient, we measure the 7 genes, and then we'll take the median of those, sorry, any one of these 6 genes, and then we'll take the median of these 6 genes and produce what we call an interferon score. It sounds much more clever than it is, but it's useful. And what we can do then is, if we measure patients at any age, effectively, these are control values, these are patients, and what we find is that at any age, almost always patients with AGS have a high interferon score compared to controls. Now, unless you're working on AGS, don't worry about that. But what I'm trying to get at is it's a tool that allows us to identify patients with AGS before we do a gene test, for example. It's a screening tool. And we published that some time ago now, in 2013. But what you can actually start to do then is use that tool in the context of other Mendelian diseases, but also in the context of other non-Mendelian diseases. So these are patients with juvenile systemic lupus erythematosus. These are patients, adults with lupus. These are patients with juvenile dermatomyositis. And look at these fold. This is tremendous upregulation of type 1 interferon signaling. It's amazing, actually. And if you think about, so let's take an example of where people have used type 1 interferon to treat hepatitis C. There is a major risk with the use of interferon in the context of hepatitis C, because people feel ill, they feel bad, they can even feel so depressed that they can actually try, commit suicide or attempt suicide. And if you think about how ill you feel when you have a virus, how rotten one feels when one has a virus, essentially you feel that way because you're producing this kind of interferon response. So, it's intriguing to imagine what it must be like to be effectively activated in this way lifelong. Okay, so what I'm going to say to you next is that the phenotypic extent of the type 1 interferonopathies is likely not yet fully defined for a very simple reason. Excuse me, and that is because there is no routine clinical test in medical practice that we as clinicians use for detecting dysregulated type 1 interferon signaling. There is no test that we use as medics, as doctors, to assess whether someone has too much interferon in their blood. Except, and the reason why the asterisk is there, except in Paris. I tell you, this is the only laboratory in the world that measures an upregulation of type 1 interferon. And nowhere else does it. Not even in the big, powerful United States of America do they have this test. And there are various reasons for that, but my point simply is that if you do not look, you do not find. Very simple. So if you're not looking for too much type 1 interferon signaling, you will not find it. And that's why I think at the moment it's fair to say, or to postulate, suggest, that at the moment we don't know the extent of these diseases because we don't look for them. Okay. So here's an example of that really struck home to me. This is a story that started about 3 years ago now, and I was asked to see this family, and I went to their house in the west of Scotland, and this was a man whose father was a doctor, and who this man was diagnosed with cerebral palsy at the age of 2 years, and then he developed a very slowly progressive spastic paraparesis. His daughter was born with a similar neurological disease, much more severe, however, and then she developed a lupus-like illness. Okay, and it was this combination of neurology and immunology that prompted the clinicians in Scotland to ask me if I might pass an opinion on this family. So I actually went to see them. We took blood from this girl, and she had an interferon signature. So these are controls, 30 controls, the mean of these 30 controls, and this is her. This is an incredible upregulation of type 1 interferon signaling, and this is the man. Now, she has lupus, and we know that lupus is associated with too much interferon, but he has a spastic paraparesis. That's all he has. He's completely intellectually normal, his head circumference is normal, his spinal MRI is normal, his brain MRI is normal, he has no fevers, he has no rash, he doesn't feel unwell. He has a slowly progressive spastic paraparesis affecting his legs only. So then we took blood from the girl again, and she had an interferon signature separated by a year. By this time she was much improved and with no obvious signs of lupus. But to cut this story short, we took blood from him again, we took blood from him again, we took blood from him again. And I draw your attention to the dates: April 12, October 2012, January 13, July 13. Every time we take a blood sample from this man, we find he has an interferon signature. And on that basis, we said that he and his daughter have the same disease, even though it's presenting, or there's a difference in the phenotype, and that's something I'll briefly touch on in a moment. In fact, what we did before we published, by the time we published the gene, so we found the gene in this family, essentially on the basis of this kind of information. But what you can see is this is the girl measured on 2 occasions. These are controls for each of these 6 genes. This is the girl, multiple fold increase in the expression of these 6 genes. This is the man, 5 times measured over a period of a year or so. And then this is the mother of the girl, and this is the parents of the man. And essentially, it's only the girl and her father who have the interferon signature, and that's because she has a mutation that she inherited from him. His mutation arose de novo. It was a de novo mutation in that man. He didn't inherit it from his parents. His parents didn't have an interferon signature. These patients, that family have mutations in IFIH1 or MDA5 that Alain already mentioned. This is a different child with a mutation, a dominant mutation in the same gene, with a very different phenotype, a classical Aicardi-Gouttier syndrome presenting essentially at birth, but then developing a florid autoimmune disease which led to the child's death. This is a different phenotype, again, a child with a dominant mutation in this gene. This child was completely normal until the age of 15 months, and then developed a devastating neurological disease, which now leaves this child with who's completely dependent and has no useful abilities, sadly. We described these 8 families at that time. This is the family I've mentioned already. No, so this is a different family. I just want to mention this family briefly. This is a child. These 3 bars represent the interferon signature taken over a period of several months in a child who has classical Aicardi-Gouttier syndrome. He has a mutation, and it is a proper mutation, that he inherited from his father. He has an interferon signature measured 3 times. He inherited the mutation from his mother. His mother had an interferon signature on 2 occasions. So what you can see here is that the mutation predicts the interferon signature, or the interferon signature predicts the mutation. However, this boy has devastating neurological disease. He will never have any children. Okay? His father is completely normal. His mother is completely normal. He is 40 or so years of age. She is now well over 70 years of age. So here what we have in this family is we have penetrance for the mutation clinically in the child, but complete non-penetrance in the father and his mother. We have penetrance for the biochemical phenotype, but complete non-penetrance for the clinical phenotype in these 2 people. And what this says to me, I mean, it's nothing new in the context of monogenic disease. We know about variable expression or non-penetrance. But what I think is that it says is that monogenic disease is not simple. You know, it's just to say that just because something's due to a single gene, it's not necessarily simple to understand. In fact, it may be that there are modifier genes involved. Or it may be that it's a mixture, even in this context, of both a monogenic defect and an environmental insult. And I also reflect on the fact that I don't think, and we know, of course, that the immune system and immune homeostasis is not a completely binary phenomenon. It's not on or off. It's not 0 or 1. It's a gradation. And what I would say to you, I mean, it's quite interesting when you look at the databases of genetic variants in the normal population of IFEH1 or MDA5, the gene involved here, you see a lot of variation in this gene. And I would suggest to you that maybe evolutionarily there's a balance to be struck between your ability to respond to a virus by producing a lot of interferon and at the same time the potential risk that you run of developing an inflammatory disease if you spill over into the pathological domain, if you will. So IFEH1 MDA5, this is an example of constitutive activation of a nucleic acid receptor. Okay, that's the family. So that's the family I just mentioned briefly. Now, just as a very, very brief example, I don't know if there are any neurologists in the audience, but we also described ADAR1 to be associated with a phenotype which is called bilateral striatal necrosis, affecting a particular part of the brain, the basal ganglia. And these basal ganglia here, you can see they're whiter than the rest of the brain. This is abnormal. And then very sadly they shrink over a period of a few months, and this is associated with a devastating dystonia. These patients have a very, very severe neurological phenotype, and I only mention it because when we started ascertaining patients with this phenotype, what was clear was that these children were completely normal until something happened, and the something that happened in these cases seemed to be a viral infection, which in my opinion may well have triggered the disease. So you have an example of a monogenic susceptibility, if you will, that's pretty penetrant but not completely penetrant, but you, at least in some cases, quite clearly need a trigger, which in this case I think is environmental. Now that's anecdotal, that's I'm suggesting something, I haven't got definite proof of that, but I'm reasonably convinced of it as best I can be. And I just point out this also, this is a woman, these are the brain scans of a woman who has a child with classical AGS presenting very early on in life. It's due to a dominant mutation in ADAR1, which is the same gene I've just mentioned, causing this bilateral striatal necrosis. Her child has devastating neurological illness. She was said to be completely normal. But in her 30s, she had a car, well, so yeah, late 20s, early 30s, she had a car crash, and she was found, and because she'd hit her head, she had a brain scan, and she was found to have these changes. And I'm not going to talk about it further, but intracranial calcification, this is a CT scan, and these abnormal white pieces are calcium. And she actually is developing features now of a neurological disease, which is completely distinct from that of her child, but she has an adult onset disorder associated with too much interferon. They both have an interferon signature, and it's due to ADA1 mutation. So it's quite clear that you can have adult onset diseases associated with at least certain mutations in certain of these genes. But in the same family, the phenotype is tremendously distinct. And again, monogenic disorders are not necessarily simple. Okay, so I'm going to whiz through the rest very quickly. We know that AGS is associated with these skin lesions, which are sometimes referred to as chilblains. These are some pictures of these skin lesions. They are worse in the cold, they are worse in the winter months. I want to very briefly touch on mutations in this molecule called STING, which again Alain mentioned, which is a fundamental molecule. I mean, it's incredible to look at the literature related to this molecule. It's involved in fighting infection, it's involved in autoinflammation, it's involved in cancer. This is a crucial molecule, and constitutive activation of this molecule leads to this disease called STING, called some kinds of, as has been referred to as SAVI, STING-associated vasculopathy of infancy. And this is a disease that essentially mixes in variable amounts, depending on the patient, skin disease and lung disease. We've already seen this picture earlier on, but you can see this can be devastating and has some overlap with the kind of skin lesions we can see in Aicardi-Gouttier syndrome. And indeed, this is a woman with a dominant mutation in TREX1, the AGS1 gene, who has this really devastating, very deforming disease, which is pretty much exactly the same as that, I would suggest. And I suggest to you that the phenotypic overlap between mutations in TREX1 and mutations in STING is because there is pathological overlap, and I would suggest to you that pathological overlap is associated with too much interferon. It was based on the fact that there's too much interferon. This is a boy that we've seen personally. There's a family that was described by Frédéric Loca and his colleagues last year, which is a familial case where this girl has life-limiting, or it would be life-limiting if she wasn't treated, lung disease. Her lung disease would kill her. She inherited the mutation from her father, who's dead, and he inherited the mutation from his father, who's alive in his 60s, I believe, and who has minimal features of disease. Okay, so again we see interfamilial variability. They have an interferon signature. I think this is an interferonopathy, and it's an example of enhanced sensitivity, or indeed constitutive activation of an adapter molecule. So this is downstream of the receptor for DNA, but again it's constitutively active. And I'm just going to touch on the fact that a certain number of patients with non-syndromic lupus have been described with mutations in TREX1, the AGS1 gene, that you can find monogenic causes of lupus due to monogenic mutations in TREX1, or indeed due to monogenic mutations in IFI-H1. This wasn't quite non-syndromic, but essentially the presentation was systemic lupus erythematosus. And that's the very same gene that I've been talking about in great detail, the man with spastic paraparesis who had the daughter with spastic paraparesis and a lupus-like illness. So we're seeing lupus effectively being induced by single mutations, and I think that lupus is at base, at least in some contexts, at base an autoinflammatory disease with spillover into adaptive dysfunction. So that's a slightly controversial stance to take, but it doesn't matter. I can do that. And then we've also been searching for monogenic causes of lupus, and just to mention the fact that we can find them, or you can find them. They're rare, they're difficult to find, but they do exist. There are complement deficiencies been known for many, many years, but these people have proper lupus. They fulfill the American College of Rheumatology criteria for a diagnosis of lupus, and in this case it was due to mutations in a gene called ACP5, which codes for this molecule. And people are still trying to work out how mutations in this gene and how dysfunction of this protein cause lupus. Okay, so very quickly then, the whole point about this, from my point of view as a clinician, is the idea that if you understand the phenotype, or if you recognize the phenotypes, if you understand the genetics, if you then can understand the cell biology, you might reasonably be in a position to imagine that you could treat these disorders. Because if you believe that these diseases are due to too much interferon, as I mentioned at the very beginning of this talk, if you believe that these diseases are due to too much interferon, then treating the interferon or blocking interferon signaling may be reasonable, a reasonable way in which to approach this problem. So you can start to develop a schema. You can block the generation of self-nucleic acid. You can block sensing of self-nucleic acid. You can block signaling from the nucleic acid sensor. You can block the type 1 interferon receptor itself, or attack or block the interferon molecule, or you can block downstream of the interferon receptor. And people are developing, this is a very hot topic for various reasons, not probably least of all because of these monogenic interferonopathies, but particularly I would suggest because of the recognition that interferon is important in systemic lupus erythematosus amongst other diseases. But people are developing molecules that block CGAMP, CGAMP or CGAS. There are pharmaceutical companies that are very interested in blocking DNA sensing within the cytosol, and there are mouse models that suggest that that would be a good approach. One could try and block parts of the sensing or the responsive mechanism, so TBK1 blockers, for example. One could try and block interferon itself or the interferon receptor, or one could try to block downstream of the interferon receptor, and I'm talking really on behalf of other colleagues in our department, but this is a very brief story of a boy and other children with that I've already mentioned, in fact, with STING gain-of-function mutations. This boy has a very devastating disease, and this is him after about 12 months of treatment with a JAK inhibitor, which blocks downstream signaling downstream of the interferon receptor. And there's been a very pleasing response to that treatment. It might not be perfect, there are various issues about dosing, but this seems to work in the context of STING mutations. This is a different child from the south of France who's, it's just a visual confirmation that this treatment is really working rather well. And we can look at other indices. The CRP, one of the children has very high CRPs, the other two that we've been treating did not. We see an effect on hemoglobin. We can see an effect on the weight. So this seems to be a useful way of trying to address this problem. Now, I can't say for definite that this medicine is working by blocking interferon. It blocks downstream signaling of the interferon receptor, but it's a JAK1, JAK2 inhibitor, so it might be doing other things. And until we have a molecule that effectively its only action is to block interferon, I cannot say to you that the concept of the human type 1 interferonopathies actually holds any merit. It's only, I think, when we have a treatment that's specific to interferon and we use it in these patients with putative human type 1 interferonopathies, and we see that that treatment works, that we will be able to say that there should be such a concept as the human type 1 interferonopathies. And until that time, I would say to you, it's an hypothesis. Yeah, we don't need to go into that. So I will end with a little bit of imagination. I've said to you that we misrepresent self for non-self. And my question then is to you, where does the self DNA or RNA come from? In which biological processes do you derive the self-nucleic acid that is then sensed as mis-self when you have mutations in these genes? And the hypothesis here is that it's something to do with the junk DNA. This is the portion of the genome that codes for genes, 1% or so, and this is all rubbish, as people say. And in fact, when you go back and look at the rubbish, it's very interesting because you can start, as if you're searching for fossils, you start to find that rubbish, a considerable proportion of that rubbish, is actually derived from ancient virus that has gained entry into our genome and has made its home within our own genome. And the point about that then is that potentially that viral genetic material that has come into us and been endogenized maybe has a life of its own, has a will, wants to propagate itself, wants to make more copies of itself, and it would seem, evolutionarily speaking, that we as humans would have ways of controlling that possibility. And I would say to you, the hypothesis here essentially is that some of the genes, some of the proteins that are dysfunctional in Aicardi-Goutieres syndrome, for example, might be involved in controlling endogenized viruses that have come from the outside. Okay, and just to say that this is a real phenomenon. There are examples, there are more than 100 of these examples where bits of these ancient viral sequences have actually jumped de novo between a parent and a child into a coding gene and caused a mutation, which is then recognized by the clinicians. But of course, if most genes, if most of the genomic DNA is actually not coded, if 99% is non-coding, there could be quite a lot of this happening and you never recognize it. Not only does it have to jump into a gene, but it also has to jump into a gene that's actually a dominant phenotype, or at least an X-linked recessive phenotype, to actually be expressed. So, it probably happens rarely, but it does happen. And what's suggested here is that, for example, in the context of TREX1, is when you capture, and there are some issues about this experiment, but when you capture the DNA in a TREX1 knockout mouse cell, what's been suggested is that a disproportionate amount of that self-DNA actually can be mapped back to endogenous self-DNA, endogenized retrovirus. And if you want to, you can make a case for most of these molecules that are mutated in AGS to be associated with retrotranscription. So that's the situation where you have a virus that's embedded itself in our own nucleic acid, pardon me, and then you get transcription to make a piece of RNA, and then you have reverse transcription. And that makes a piece of DNA, and then you do that twice, and so then you make a second strand of DNA. So you have double-stranded DNA from this piece of DNA that then reintegrates. And this is what retroviruses do. And we know that TREX1 is important in the control of the human immunodeficiency virus, HIV, SIDA, that's actually a retrovirus coming from the outside. And we know that SAMHD1, the AGS5 gene, is associated with HIV restriction. So again, we see that these two molecules are both involved in controlling a retrovirus, but this is one that's coming from the outside. But on the basis of these studies, a group has tried to treat the TREX1 knockout mouse with reverse transcriptase inhibitors, which are used in HIV. And according to this study, which to my knowledge has been reproduced by one other group, but also has been another group I know of has failed to reproduce these data. But if this is the TREX1 knockout mouse with 75% of them dead by 30 weeks, and these are mice where the mothers and then the mice were treated with reverse transcriptase inhibitors and apparently salvaged. It's on the basis of that kind of reasoning, on the basis of that experiment, essentially, that we, myself and Stéphane Blanche at Necker, are treating a set of patients with Aicardi-Gouttier syndrome with reverse transcriptase inhibitors to see if we can maybe control the production of type 1 interferon, and I won't go into that. But what we're doing is measuring the interferon response according to the exposure to these drugs. And so I will end there and just say thank you to all of these people and these people that sponsor our work. Thank you.